We host sessions on a quarterly basis. And many of our sessions and a lot of the attention throughout the nation really addresses trauma and resilience that's focused on children and youth. And that is absolutely a very important population on which to focus because there's so much opportunity to both focus on prevention as well as intervention. That said, it's also really important for us to think about the impact of trauma and opportunities for resilience among older adults. And so that's what we're going to do today, because surely as a result of the passage of time, many older adults have faced traumas, whether they've been in part of war, they've lost loved ones, they've been through a famine, natural disasters, there are other family events, racism, discrimination, or any other number of events. They will have likely experienced some level of trauma. That does also mean there's been more time for healing, but not everyone has that ability or the skills to do it. They may not have the language that younger generations may be more familiar with regarding their experiences, and then as a result may process the experiences differently. There's no better or worse, it's just different. Also, as we age, we experience new life events that can either be traumatizing or re-traumatizing. Again, that could be loss of a loved one, more physical ailments, mental health concerns, loss of independence or a sense of home, if you're being moved into a facility, for example, or leaving the community setting. We also know that both formal and informal caregivers have to navigate trauma. They have their own experiences that might surface when caretaking, or they may have secondary trauma. And all of these issues are complex, and they're very important to consider for policymakers and programming. And we are so excited today to have three panelists joining us to help discuss these issues. We have GiGi Am, who's assistant professor for Virginia Commonwealth University. Kelly O'Malley, who's a clinical psychologist with the VA Boston Healthcare System, and Shelley Rudnick, Associate Vice President for the Jewish Federation of North America. And I want to encourage all of you in the audience to chime in during the discussion. You can use the chat, you can raise your hand. We really like to have active participation in the sessions. And this will be in a Q&A format that I will moderate. So I'd like to start with Kelly. Kelly, can you please introduce yourself and talk just a little bit about some of the unique challenges you've observed among older adults who have experienced trauma?
Yeah, thank you. Thank you, Lauren, for the introduction and setting the stage for our meeting today. I am the clinical director of the mental health services for VA Boston's Community Living Center. And so for folks who are less familiar with VA, that is our version of a skilled nursing facility. And that can include everything from subacute rehab to long-term care for individuals with cognitive impairment or more profound physical ailments that they're no longer able to live in the community, as well as hospice and palliative care. And so I provide direct clinical care services to those folks, and I supervise interns and fellows in that setting as well. And some of the unique challenges that we see is, as you mentioned, Lauren, in the introduction, is that as folks are facing greater physical limitations due to illness or exacerbation of illness or new medical conditions, maybe not being able to return to the home that they came from due to those limitations, they're in these medical settings that can often lead to less feelings of control and more feelings of vulnerability, which can sometimes exacerbate existing past symptoms of trauma, can lead to a reemergence of memories of past traumatic experiences, and can also really lead to an exacerbation sometimes of symptoms. And then for those folks, it can be really hard if they're not able to access their previous coping strategies. Maybe it was going out and taking a walk, these things that they're not have accessible to them anymore. It can really lead to a lot of difficulty engaging with the healthcare system and their providers. There's a lot of lack of trust there at times. And then when we have individuals with cognitive impairment, we know again that their coping strategies are not as accessible to them, and they may really misperceive their environment. So it may seem more threatening to them. They may misperceive the intentions of care staff that are coming to take care of them. And so we can see more disruptive behaviors or distress behaviors in that setting.
Thank you so much, Kelly. That was so eloquently stated. I really appreciate that. Shelley, could you please briefly introduce yourself and share your thoughts about the need for trauma-responsive care among older adults, just at a high level? We'll get into more details shortly.
Sure. Thank you so much. Again, my name is Shelley Rudnick with the Jewish Federations of North America's Center on Aging, Trauma, and Holocaust Survivor Care. Our mission is to advance person-centered trauma-informed care for Holocaust survivors and all older adults who have a history of trauma and their family caregivers as well. And as we know, the Jewish Federations have been working with Holocaust survivors for many years, who by definition all have a history of trauma and are all aging now. But we've learned that the principles that work really well when working with Holocaust survivors also are broadly applicable to all older adults who have survived trauma. And that is by making this trauma-informed framework universal, we'll be able to help anyone from Holocaust survivors to veterans, refugees, survivors of floods or hurricanes or domestic violence or car accidents or you name it. And actually research that we read coming out of the VA shows that up to 90% of older adults will have experienced at least one traumatic event in their lifetime. So that's really everyone. So we really espouse to make the person-centered trauma-informed approach the universal strategy for serving all older adults. And as Kelly O'Malley just stated, many of the trauma symptoms emerge later in life when they hadn't before because of the changes that the aging process involves. You know, role changes or relocation or loss of previous coping mechanisms are all factors that can bring upon this change as people age. And so what we found is that if we don't use a person-centered trauma-informed approach and take into account that there is a history of trauma, we risk, at worst, re-traumatizing the very people that we're trying to help as we're serving them, re-traumatizing them by making them feel unsafe or making them feel there's not enough food or making them feel that they don't have the trust that they need in order to get the quality of care that we can offer. So we risk re-traumatizing or the people that we're trying to help just not being able to access the services because of those trauma symptoms. And so by using a person-centered trauma-informed lens and recognizing that there is this history of trauma and we need to adapt our policies accordingly, we'll be able to better help the people that we're actually trying to serve.
Thank you so much, Shelley. That was fantastic. GiGi, if you could introduce yourself and also tell us, we know you've worked with the state of Virginia, so would love to hear a little bit about your work and how you've worked with the state to advance their efforts.
Sure. Thank you, Lauren. Thanks for having me. It's really great to be in conversation with you and Kelly and Shelley today. My name is GiGi Am. I'm assistant professor at Virginia Commonwealth University, where I work in the Department of Gerontology and with the Virginia Center on Aging. And in that capacity, I'm also the director of our person-centered trauma-informed lab, which focuses on education, research, service, and practice. And a big core of our work really has been to work with our state unit on aging. That's the Virginia Department for Aging and Rehabilitative Services, and our state Medicaid agency, the Virginia Department of Medical Assistance Services. Really both very forward-thinking state agencies, creative and innovative. And in our partnership with them over the last, 5 or 6 years, we really have focused on creating training related to trauma and resilience among older adults, thinking about that developmental stage of life known as elderhood. And with our state unit on aging and our state Medicaid agency have developed curriculum and delivered curriculum for the home and community-based services workforce and the nursing facility workforce. So it's been a long and creative journey with them. It continues to evolve with our state Medicaid agency. We call them DMAS, that's their nickname. We just released a trauma-informed toolkit for nursing homes, and that was developed in partnership with several hundred nursing home employees and an advisory board that included family members of residents of nursing homes. So while it was specifically developed for nursing facilities, I think it has wide applicability to any organization or person working with older adults. And I think Andrew will drop that link in the chat.
Thank you so much. It's I really, really appreciate your ability to speak to some of that Virginia work. I know we talked to somebody in Virginia and unfortunately there was a scheduling conflict. So appreciate you serving as that representative in addition to talking about the many things that you're doing with VCU. So Shelley, I wanted to hear a little bit more from you about what trauma responsive interventions or programs have proven the most effective. I know that the way that, and you can talk a little bit more about how you operate as an organization, and explain that perhaps.
Unmute. Thank you so much. So we operate in two ways, actually, is how we advance person-centered trauma-informed care. One is that we issue subgrants to local organizations to develop innovations in person-centered trauma-informed approaches. So what that means is there might be a local organization that has a physical health program or a cognitive health program, and we provide funding so that they can design that program in a way that is person-centered and trauma-informed, and using the principles that we've developed along with SAMHSA of the person-centered trauma-informed model. And I can share that model with you in the chat in a moment. So we issue subgrants, and then we also provide a suite of educational opportunities such as webinars and in-person trainings and written materials and everything that's all available on our website as well. In terms of the question of what strategies or interventions have proven the most effective for certain populations, for either Holocaust survivors or immigrant populations, we actually don't rank effectiveness. So my answer won't tell you which have proven most effective, but I can tell you that the use of culturally aware practices and choices is essential. So that goes to everything from the choice of foods, right? If you have a food pantry that is serving mostly people who are immigrants from Russia, you wouldn't have the same foods as people who are not immigrants from Russia, because they may not recognize the foods or may not want the foods or may not know how to open the package of this, weird, obscure American food, like those like crescent roll packages, which are super weird and obscure and hard to open, but they might not have those in other countries. So you make sure that the food that you're serving or providing is culturally accessible. Everything from family relationships and knowing how families speak with each other, to celebrating holidays or not celebrating certain holidays. For example, we know in the Holocaust survivor community, there are several dates on the calendar that mark observance of the Holocaust, and some are more relevant to certain cultures than others. For example, those who are of Russian descent mark VE Day as a much more significant date on the calendar than Holocaust Remembrance Day. And so it's important to keep in mind, the calendar and what is most important to the people that you're serving. And then also recognizing that certain groups, depending on who you are serving, may have cultural histories of abuse in certain ways. So for example, the African-American community may have aversions to things like medical experiments because of abuse in medical experiments that were performed on African Americans historically. Same thing with making sure that we address people by their last names, if it is their culture to do so, as a sign of respect. And in many cultures, first names are just fine, but in others, it would be a sign of disrespect to address someone by their first name. So being culturally aware of those practices makes for more effective and accessible programs, no matter what the program is.
You're on mute, Lauren.
Thank you. Sorry, I thought I went off mute. Instead, I went on mute. So Kelly, if you could talk a little bit, answering the same question, but thinking specifically about your experience working with veterans, and what kind of interventions or programs have you've seen to be effective?
Thank you. Yeah. And again, I should have mentioned this when I started, when I introduced myself, but I do also just want to reiterate that the views that I express here today are my own, and they don't necessarily represent those of the VA or the US government. But some of the areas that I know that we've really been focusing on trauma histories and using a trauma responsive approach to care is with our homeless veteran population, and especially as that population is growing older as well. There are really a lot of, as Shelley said, a lot of cultural factors that are at play that can really affect their engagement with the programs that are trying to help them find stable housing or help them get reconnected to the VA so that they're able to access the medical supports that they need. And given some of their histories, it is a little bit more challenging. And so they're really using a strong trauma-informed lens in ways that they're engaging those folks to help increase their access to care. I know that we've done a lot of work too with our women's health programs and previous trauma histories or trauma experiences there, and how we can support female veterans at the VA. And in my setting in particular, I work very closely with our providers across disciplines, including our social work team, to really make sure that we're assessing for trauma history when folks are coming in to our setting, and then making sure that we're really including trauma-informed care recommendations into their care plans. So in these skilled nursing facilities, we're required to have like a structured care plan addressing each element of this person's care while they're with us. So whether that's treating high blood pressure or fall risk or anything like that, we have to have very specific outlines of what we're going to do to address those, how we're going to make sure that folks aren't having falls, et cetera. And so one of the things that I've been really working with our staff on is developing, first assessing if someone has a trauma history and what they're maybe experiencing in the moment, and then making sure that we're putting strong recommendations in their care plan for all of the care team to see in ways that they might consider how they enter the room, how they might set up a space if they're needing to, care for someone or do a wound dressing, for example, that they're really setting up a space that makes that feel as comfortable as possible for the individual that they're caring for. I know that nationally, our National Center for PTSD has a website, and they have information on trauma-informed care practices there. And so it is definitely something I think with our population that we've always been thinking about. And of course, as we're seeing the growing population getting older for us with veterans, we've definitely been thinking a lot more about that in many more of our care settings.
Thanks so much, Kelly. And I do want to encourage, I've got more questions and I'm going to keep asking them. We don't typically pause for like Q&A specifically. We just go until we're out of time or until we're otherwise done, which has to be by the time we're out of time. But if folks want to use the chat and ask any questions that you might have, or if you have experience with some of the things that you're hearing about today, we'd love for you to kind of weigh in and share your experience as well. I know our speakers always like to hear more stories too. So, and you are welcome again to go off of mute and ask a question too. I just know chat is often the preference of our participants. In the meantime, GiGi, can you tell us a little bit about, from your experience in capacity building within the home and community-based services arena, what are the most critical elements of trauma responsive care that should be prioritized?
So I'm trying to limit it to about 4 areas. I mean, this is one where it would be wonderful to have just like individual conversations, because every community, every organization is on our own journey. And so that answer probably would be really different depending on the organization or the community. From my experience in working with our home and community-based services system here in Richmond, led by our Area Agency on Aging, the SPAN Center, I think there are a few places that HCBS providers are really kind of naturally are already working, and where there are opportunities to expand our work. Um, if I'm sure a lot of folk on the call are really familiar with the SAMHSA principles of trauma-informed care. And a lot of that really intersects also with the model that JFNA is using with person-centered trauma-informed approaches. For me, I think the opportunity in our aging network is to really think about what does that principle of historical, cultural, and gender issues, what does that have to say for our communities in the context of age? So often in discussions around intersectionality, age is not included. That's ageism, right? To leave out the experience of age as a developmental influence on our lives is to leave out a significant part of the story. And so in our work with home and community-based services providers here, we spend a lot of time talking about ageism, both as a potential or a traumagenic experience, a potential experience of trauma in the community. Everyday instances of ageism can influence our health and well-being and our mental health. And also the companion to that is the developmental stage of elderhood. Elderhood offers specific opportunities and milestones and purpose. And these two, can kind of work together to understand that intersectionality around historical, cultural, and gender influences. And then I think related to that, what we've seen here in Richmond is sometimes some of those data points, right? And so to be able to understand the community that we're serving, we have to know who they are. And oftentimes that occurs through data and disaggregating data. And so to the extent that we're not asking questions about who you are, then we don't really have the full sense of that. So, for example, in many of the Title IIIB or Title III or Older Americans Act services through HCBS, the data element of race is not required to be asked. But there are important reasons to ask that. And there are ways that we can help older adults understand why we're asking about who they are. Because to not know these pieces, to not know or ask sexual orientation, for example, so in my state, in our data collection at the local level, sexual orientation is not a required element under our state uniform assessment instrument for older adults. But it is important to understand the historical and cultural and gender influences on someone's life. And we've have found great success in our community in training providers to understand why we're asking and just to offer older adults the explanation and reasons for asking demographic variables. And people always have the option to say, I'm not comfortable sharing. But I think moving ourselves toward understanding that data collection is an important part of any care plan. It's an important part of understanding who the people are that we're serving. And it's also an important part of being able to hold ourselves accountable for measures of impact related to health and racial equity. If we don't know who we're serving and what the impact or satisfaction rates are and differences in demographics, then we don't know whether we may be, in fact, perpetuating kind of stereotype or discriminatory practices. So I think data, as you can see, I'm having a hard time stopping talking about it. So this one is a big one for me. But I think another area where our home and community-based services providers just naturally work in a trauma responsive way is in the arena of social connection. And if you, Lauren, said to me, put all your eggs in one basket, I would put them in positive social connection, period, across the lifespan, from infancy until old age. Because the evidence says it, right? That when we have strong positive relationships, that is protective. It allows us to feel motivated and even practical, aspects of getting good information and getting access. And I think our home and community-based services organizations are experts at that. That's what this work is about. It's relationships, right? We're in it for people's lives. And so social relationships not only are our friends and our family, but they are our clients and our service providers. We did some really great work at the peak of the COVID pandemic, where we had focus groups with Friendship Cafe managers and older adults. And, what we heard from our providers during that study, that period, was our elders are helping us just as much as we're helping them. Like the healing and the reassurance and the anxiety and the soothing that's happening is coming from my clients. And cafe managers or congregate meal site managers were talking about people they've known for decades who are their clients, but they're in relationships. So I think the social connection piece is a big part of what's already happening and helping our providers to make a connection with why that's so important. And then I guess the last thing I would say kind of goes back to the work that JFNA is doing, and this is not new work. The trauma responsive or trauma informed framework may be a new and additional way of thinking, but our network has been working in person-centered frameworks and ways for a very long time. And so helping people to understand you're not starting at zero. If we're working in a person-centered way, we're moving toward trauma responsiveness. So now let's think about how to make those connections. So there's some bridge work, I think, that can be really impactful.
Thanks so much. That's awesome. And I know, we talk a lot about ACEs and protective factors, and you importantly point out that a lot of what can work for younger people can also work for older people. And we know that those social connections and those relationships are really important, particularly for people who may be more isolated too, who, because they are not maybe as physically able as they used to be, or may have other challenges. So that's a really important point to remember. Kelly, can you talk a little bit about training and how we can train and support caregivers who work in diverse settings, including nursing?
Yeah, so I've talked with a lot of staff in our CLC settings across, the Northeast region primarily is where I've been talking to folks, but every direct care worker that I've talked to has really shared with me that one of the things is they just don't know what to do if someone discloses a trauma experience. They feel like they're not sure what to say or what to do or how to respond. And so I think when we're thinking about our training elements, really helping to give folks language on how do they, what do you do if someone shares an experience with you? And I know this is some of the work that my team and I have done, and we've put together some videos that are available on YouTube that really just illustrate how people can respond to disclosures. We also, one of the things that we're learning too as we're talking to staff is that there's still a strong misconception about who's quote unquote responsible for trauma responsive care. And oftentimes it is believed to be a domain specifically for mental health providers. And so oftentimes, we'll get folks will reach out to us and they're concerned because someone has shared something with them, or, they're having these memories, or, not necessarily flashbacks, but just more of this re-engagement with these past traumatic experiences. And there's often, this uncertainty again of what to do, what to say. And so they reach out to mental health. And we are certainly happy to support all of our residents, but I think really helping the direct care staff and really anyone in a skilled nursing facility who's interacting with, residents in that place, is to just have this understanding of how they can practice in a trauma-informed or trauma-responsive way that doesn't require a mental health professional. Many of our folks, don't their trauma experiences or their symptomology doesn't necessarily require mental health treatment, and they don't need or want that. But they're trying to make, as GiGi was saying, these social connections, these positive social connections, feeling supported by the people in their environment, sharing their experiences with others. And so I think one of the main things, there's lots of things that I could talk about, but for me, one of the things that I'm really hearing from the staff is we need some language. We need to know what to do when folks share this with us. And we really want to make sure that we know how to set up a safe environment so that when we do go in to provide care, or we're, coming in the morning when someone is first just waking up and getting oriented, that we're not doing anything that is, sending them back to this scary place or triggering these memories or making them feel uncomfortable and re-traumatizing them. As far as how to do that, what folks have really shared with me is, the videos are great and these online trainings, and they love having access to them, but they're really hungry for face-to-face interaction. They want someone to come in and role play these and really help them build skill and learn how to do the behaviors of trauma-informed care or trauma-responsive care. And so they're really looking for this interactive, skill-building, face-to-face type training.
Thank you so much. I don't know if anyone wants to respond to that, because I know you're all involved in different ways and trainings. I don't know, GiGi, if there's anything you want to speak to with regard to your approach with your trainings.
Well, what I really connected with Kelly, and it looks like there's some comments in the chat. I can't tell if they're tagging on as well, but I think what I was hearing, and Kelly, what you were saying is that the social connection, we are therapeutic with one another, right? That the relationship is therapeutic, the positive sense of belonging and connection, that while we don't have to be clinicians, that positive connection with one another does have a therapeutic effect. I mean, that's what social connection does. On our trauma-informed care toolkit, we also have some training videos. I love the idea of languaging, and I think there are pieces out there. I think I hear that from home and community-based service providers as well. And I think it's a longer conversation, but maybe the three of us could just think through, like, I think a most basic response is, thank you for sharing that with me. Just an acknowledgement, because so often, depending on the nature of a specific life event, it may also be couched in denial or shame or secrecy or elements of please don't talk about that, right? And not just a creative opportunity for just narrate what we would call in my class narrative agency, right? Acknowledging what someone has expressed and creating opportunity. And but I think it comes with a whole host of other things, right? Because to then prepare and talk with our staff about what it means to hear and accept and listen to a story about trauma, that may mean there's a larger responsibility within the organization to support the staff who are hearing stories that of trauma disclosure that may also touch upon their own life history. So I think the language piece is very important, and for organizations to think about, and what does this mean if we're going to really ask our staff and train our staff to receive disclosure stories? How are we supporting them in a supervisory or reflective kind of relationships?
Thank you, Gigi, and thank you also for pointing out Ashley's question. I had my notes, unfortunately, I didn't see the chat pop up. So Ashley was asking about or talking about how discouraged they are with regard to the fact that state and federal policies are not typically very trauma informed. And you stole my thunder with one of the questions that I had in terms of what policies our speakers have seen that either are working well or changes that you would like to see in policy. So if you've seen something that's positive or that is a promising practice or where there's an opportunity for change. So I'm gonna go a little forward in the questions and then I'll go back again. So Shelley, do you want to kick us off there?
Sure, thank you. And I agree, so many government policies are not trauma informed, but that tide is shifting. I really believe it is. Our program, for example, is mostly funded by the federal government within the Older Americans Act in HHS. And they have funded us in part to develop, the model of person-centered trauma-informed care and show how it is applicable to so many different situations. And because we have a partner in HHS, in that government agency, they're able to liaise with other agencies and on other programs to share the knowledge of what we have learned and what we have developed. It is a slow process, but it does work. And I can give a couple of examples actually of it working. One is with the National Family Caregiver Strategy, which came out in 2022. It was the result of the Raise Family Caregiver Act. The federal government was tasked by Congress with coming up with guidance to state, local, nonprofit actors on how to best support family caregivers. This was, it's hundreds of pages and many stakeholders and many meetings resulted from this act. And as part of that, we were able to contribute all of the information and data and examples that we have about how trauma impacts the family caregiving experience. You have trauma within an older adult, trauma within adult children, trauma within siblings, and often when these family or friend caregivers are involved, there are things and relationships within those families that make the provision of service harder, things related to trauma. And so by addressing the fact that there could be that some of the reasons why this service is not accessible or why this family is not translating this document literally for their older adult who doesn't speak English could be a result of prior trauma. And so we really need to be aware of that. And so we were able to make these suggestions into the National Family Caregiver Strategy, and ultimately they were adopted. And history of trauma is one of 4 cross-cutting themes in that strategy. And there were only 4 of them. And so it just goes to the council that produced this strategy felt it was very important that people recognize that trauma is within caregiving relationships, and there are things we can do about it. Because of that, other government programs and funding announcements that have come out have required their applicants to include a focus on trauma, which means they have to at least look it up, right? In order to be successful and learn some of the language and learn how trauma impacts whatever, program they're trying to run. So that's a multi-year process and multiple years until the funding gets through to all of the different implementers who are implementing these family caregiver programs. But it does work, and we're working on similar strategy with other memos and guidances that come out from different government agencies to just start to get the language in there that person-centered trauma-informed practices would be very helpful in this situation, and that applicants ought to be mindful of that. So that's one strategy, a policy strategy that we're working on.
Thanks so much. Kelly, in your experience, how can healthcare systems like the VA serve as models for integrating trauma-responsive policies?
Yeah, I think that's a really great question. I think about how VA has really successfully implemented many innovations. One was, really integrating mental health providers into a variety of medical settings, and really sort of being, doing a lot in the groundswell of that. And I think following similar blueprints to that, and again, knowing that this is more of sort of a national level program, I don't know all the specifics of how they've done that. But I do think they have really good foundational work on how they've been able to sort of diffuse these practices across a wide range of settings. So, I know that we're doing it on our homelessness program, like I said, the Women's Health Clinic. And so I think we are starting to expand this work across a variety of settings that are working with older adults, older veterans. When I was thinking about some of the policy work, I was also thinking about, the Center for Medicare Medicaid Services guidelines, right, that now requires skilled nursing facilities to assess for trauma histories, current symptoms of PTSD, and again, make sure that this trauma responsive approaches are included in these care plans. And so again, there's a federal policy there that mandates at all skilled nursing facilities that this work needs to be done. And so I think, thinking about further down the road, kind of how do we help these facilities do that, not just, community facilities, but also in our VA facilities. And so that's some of the work that we've been thinking about too, is how can we help get these practices out more broadly in our skilled nursing facilities.
Thanks, Kelly. And GiGi, your perspective on policy making and either things you've seen or would like to see.
Well, I'm kind of circling the same place as Ashley, Shelley, and Kelly, that this is incremental work, and there's kind of a long arc of moving the practice into a truly trauma-informed lens. So like Kelly, I appreciate and I'm grateful for the CMS guidance related to trauma-informed care, just having that piece there. And I think you sort of can see that in administrative rules and regulations, kind of beginning to permeate, like in the APS recent final rule that requires person-centered trauma-informed care. We are a recipient of the ACL's Elder Justice Shelter Initiative, and the requirement of applicants to provide person-centered trauma-informed care was certainly part of that RFP as well. I think where the opportunity is now is to begin to expand policymakers' understanding and the languaging and funding around that, from viewing trauma-informed care as a one-way, one-directional strategy that relates to residents, patients, participants, people receiving services. So the way I have learned trauma-informed care, whether that's been through SAMHSA materials, through training at Eastern Mennonite University, or any other model, is that trauma-informed care is a justice model. It is not a status quo model. It is not even only or primarily a service delivery model. It's a culture change model, right? Trauma-informed care has at its heart justice and equity for everyone in a community. And that not only means people who are recipients of services, but it means the people who are providing services. And trauma-informed care, as I have learned it, has a specific bias toward direct care workers, and recognizing that very often organizations and cultures repeat internally the same sort of societal inequities and biases and discriminatory practices that are happening outside in the economy and in the society inside the organization. So I will say none of our trauma-informed policy really right now recognizes that trauma-informed care is a culture change and justice model. So we do have a lot of work to do there, right? So for me, it's like policy that begins to understand the broad implications for our communities of how we have to change for everyone in our community, and the funding component. And so I would say one of the most promising kind of trauma responsive policy efforts that I have seen came on Ageism Awareness Day, when Senator Tim Kaine from Virginia, along with Senators Casey, King, and Sanders, wrote a letter to the Agency for Healthcare Research and Quality, asking them to do a study on the implications and cost of ageism on the healthcare system. And they asked 3 questions. What is the full scope of ageism within healthcare? What is the impact of ageism and intersectionality on the micro and macro levels of healthcare related to health equity and outcomes? And what is the evidence for interventions to address ageism and promote age inclusivity in healthcare? So for me, this is one of the most trauma responsive requests coming from policymakers, because ageism can be experienced as a trauma itself, as a collective and individual trauma, but also when providers and systems hold ageist structures or ageist beliefs, we're a barrier. We've become a barrier to treatment, a barrier to healing, and a barrier to growth. So I was thrilled to see these senators present that letter and offer the opportunity to look sort of structurally and societally at one of the biggest barriers to trauma recovery, and which is ageism.
Thanks so much, Gigi. And I have a question about something you mentioned earlier. So you talked about the training that you developed for nursing facilities and providers. Is that a training that's required within the state of Virginia, or is it optional? Like, how do the providers learn about it?
Right. Well, that's a great question, and thank you. So we've developed training for 2 arms with our state unit on aging that was developed through our No Wrong Door Virginia, which is the Aging and Disability Resource Center initiative within our state unit on aging. It's not a required training, but it's a free training that's offered online through our state unit on aging, DARS, and that is promoted through them and exists for, I think probably in anyone. I don't know if you'd have to be from Virginia, but it was designed for Virginians. And then with the state Medicaid agency, when we designed the trauma and resilience training for nursing homes, we provided that training in person. And you're right, Kelly, people are hungry for meaningful training. We even provided training for like the night shift at 3 a.m. We had one nursing home say, well, could you come do this at shift change at 3 in the morning? And we're like, yes, we can do that. And so some people fell asleep during it, but we thought that's probably exactly what the most trauma responsive thing is, to just let you have a minute to rest. How people learn about that is now through the toolkit, which we dropped that link. That was then kind of the second phase. We spent the first phase really interviewing and doing focus groups with CNAs just around their capacity, how they think about trauma, resilience, stressors in their day-to-day work. And so this training was designed with their input. And I'll tell you one way that the CNAs really made a difference in that training is, of course, we went into it thinking how important it would be to talk about self-care. When we talked with CNAs, we really heard a lot of just anger around the term self-care. It's like, this is one more thing you're going to ask me to do? Do you understand what I am carrying all day long? And so we removed that term completely from the training, self-care. And what we did was talk about personal wellness and health that not only could be helpful for CNAs as they're doing their job, and for residents. But we try to really frame it, and this will be a helpful tool for you on the job, and just teaching some skills that can also then be easily shared with residents. So a lot of that information is on the toolkit, and as well as training videos.
Thank you. And I think you raised a good point about that 3 a.m. shift training, because we do a lot of trainings for different residential types of facilities, whether it's for incarcerated individuals or others. Really, that notion of you have to look at everyone's schedule and the hours and make it so it's possible for everyone to participate. And that extends beyond maybe the nurse aides, the CNAs, the personal care aides, but also to the janitors or the receptionists and other people, because all of those people are interacting with the residents. And they may be the ones who see them the most frequently sometimes, or have the most personal interaction or relationship. So, in considering those folks in trainings is also really important, and giving them that opportunity. So, okay, I want to continue to encourage anyone who has questions. I'm going to get to my last few questions now, but please encourage you to use the chat or raise your hand if you do have a question. I know you mentioned this, GiGi, briefly. I'm going to go back to you. Sorry, you keep getting questions here. But in your tenure as a professor, like, how do you integrate the lived experience of older adults into your curriculum? And I know you briefly touched on this before.
In all the ways that we possibly can. So part of that might look like integrating scenarios, doing case or scenario work, certainly through, assignments where we give our students opportunities to interview and engage with older adults around specific issues. I integrate a lot of film and poetry and art. By older adults about the aging experience, about elderhood into the curriculum. And then in my work in the Person-Centered Trauma-Informed Lab, narrative is just a big foundational part of that. So we've just wrapped up a really wonderful project that involved quite a few students, where we interviewed 20 centenarians in our region, and about home, the concept of home. What does home mean to you? And this is really informing a lot of what's happening, as Kelly has mentioned a few times, the real rise in homelessness among older adults. We're certainly seeing that in Richmond, as all over the country. And so when we did these interviews with centenarians, which we're now infusing into the classroom and into our training, and yeah, Jimmy Carter, Tracy, exactly. He's like our role model. We asked questions about home, because moving kind of beyond housing is like, this is the space we live in. And what we hear from centenarians are the same things we would all say. Home means safety. It means people who love me. It means a place where I can be me. It means, and people will talk a lot about food, the very specific food. So a lot of our narrative work also shows up in the curriculum, whether that's in the classroom or in training. Mm-hmm.
Fantastic. Shelley, you talked before about sort of the informal caregivers, family caregivers, and how sometimes what's being recommended isn't always going to work as well because of intergenerational trauma or potentially secondary trauma. Is there anything else like you want to kind of add to that about how we need to be thinking about family caregiving and what we can do to support those caregivers?
I think that family caregivers are hungry for information and resources, and they don't even know that. They don't even know where to begin. Many times they're in crisis mode, and they're thrown into these situations on top of all of their other life responsibilities, and don't even know that they wear the term family caregiver. And so like a website or a PSA that says family caregivers come to this support group, they wouldn't even hear it, because they don't even recognize that this is for them. So the onus really ought to be on us, not on the people the caregivers themselves, the family caregivers. The onus ought to be on the service providers to, as we work with older adults, to also work with the families and make sure that they have the knowledge that trauma exists and that it's okay to name it. That trauma, not accusing or anything like that about them specifically. Trauma exists across the board in our society. Trauma symptoms show up when people are experiencing acute situations, such as the one that you might find yourself in right now. And I think that even naming it can give a sense of relief to the caregiver in knowing that they're not alone, they're not crazy, you know, that this is hard, what they're trying to do and what they're being asked to do. So I think providing the education, basic education on that trauma exists and naming it, and that trauma does have an impact on people as they age, and trauma does impact families, gives them the language to understand what may be going on here and potentially ask for help, whereas they might not even known before, had the language to even ask for what they need. In terms of specific programs, I mean, there are respite programs, there's financial assistance programs, there are all sorts of programs, not enough, of course, but there are programs that exist to help family caregivers. But if they don't have the language or know that, if they don't have the language or know that this is even applicable to them, those programs are not accessible.
That's really helpful. Thanks. Kelly or Gigi, anything else you want to add about informal caregivers or family caregivers?
I mean, I think I'll just echo, what Gigi and Shelley were saying is that our family caregivers need this information just as much as our formal direct care workers in informal settings who are providing care. And I think, that's an area, again, when we think about, policies and support and education and how people identify and name themselves, because oftentimes family caregivers just say, well, I'm just doing what family does for family. I'm not a caregiver. And so, helping find ways to get that information to them, and the onus is on us, right? To let them know that these resources are out there and that we need to talk about, people's past experiences and how it affects them. And then I was also just thinking about, making sure that for our formal caregivers, what are the support structures? What are the ways that organization is also, preventing re-traumatization of the folks who are providing care? But what are the support structures that are being offered to them too? Because we know that sometimes hearing the stories that the persons that they're caring for could be, something that could be hard for them. It could be an experience they've had or their family members had, which can be re-traumatizing for them. And so how do we make sure that those folks are getting the support they need so that they can have their well-being and take care of themselves, right? Not self-care, but, really being able to be well and healthy and continue to provide care in that setting. And so I think those were the two things that I was really resonating on as kind of the takeaways from these past couple of minutes.
Fantastic.
I'd love to share a program we just piloted with our local area agency on aging this summer, and hear maybe from the gathered community if anyone else is kind of working in these sort of ways. We just piloted a program called Poetry on the River with a group of 8 caregivers who were all women. The majority were older adults, majority were African American, and most were caring for someone with dementia or Parkinson's. And this was a series that we designed intentionally to basically bring caregivers together in a non-demanding environment. And so we define that as a non-demanding environment meant time outdoors in nature, doing meaningful activities with people who understand what you're going through. And it was marvelous. We partnered with the Area Agency on Aging. It was the lead agency with a beautiful 100-acre historic park here called Maymont Foundation. And we spent time doing yoga in the Italian gardens, planting plants in the pollinator garden, learning specific breathing techniques and meditation techniques, and sort of self-soothing activities. We wrote poetry. They wrote collective poetry. We studied the poetry of Lucille Clifton and Parnisha Jones. And then the series culminated with a 2.5-hour boat ride on the James River. We're so lucky here. We live in this really accessible space where this gorgeous river is just a part of our lives. And so what naturally started to happen over the series was the caregivers became friends. they also had the experience that they could leave with their loved one in the care of someone else for a couple of hours, and everything would be okay. And then they got their mind off of it. And so people said things like, it's been so long since I've been outside. You know, my plants are still alive. I'm so excited to see that, you know, that they're still alive. You know, and we could see then also the caregivers just naturally, they started to help each other understand the resources, because one thing that happens when we become good advocates for ourselves and our loved one, right? Over time in that role, we start to learn the system and the language, and you could see them sharing with each other. And I hope we'll get to do it again many, many more times. I mean, there were so many moments where I was like, wow, this is my job to be on the river reading poetry with amazing women. But it was a super intervention kind of, I hate to even call it an intervention, frankly. But it was a great experience for them, I think, and for us.
Unmute, Lauren.
Thanks, guys. Sorry, I never seem to learn. We're going to do a very quick lightning round with my final question. So if you could each share just sort of, it could be something you've already said, but if you were to share one concrete strategy that people can take back to their agencies, offices, communities, it could be a policy, a program, an action, language, just something that you think people should be focusing on as a takeaway. And let's start with Shelley.
Speak about trauma as a lifespan issue. Trauma can impact anyone at any point across the lifespan. Childhood trauma, which people often give attention to, doesn't go away as someone ages. God willing, a child who experienced trauma will become an adult and an older adult, and the trauma doesn't go away. So my advice is, when talking about trauma and trauma-informed care, speak of it as across the lifespan and not only on certain segments of our demographic.
Thank you. That's great. Kelly.
I'd say, hearkening back to what I said earlier, is that this trauma responsive care is for all of us, regardless of who you are in a person's life or environment or care team, and whether you're the folks who are coming in and helping to clean the rooms, or you're the ones who are doing the wound dressings, or you're the mental health providers or the social workers, that it really is for all of us, not just one discipline and not just mental health.
And GiGi.
Yeah, everything Kelly and Shelley said, and that trauma is not the whole story. Trauma is not destiny. That there's a larger equation here of what's happened to you includes adversity, as well as you know, all the great things.
Well, I want to thank everyone for joining today. This was a fantastic session, and you guys had such insightful things to share. We will be sharing the recording on our website. And we will have another session in the winter, likely January or February. We have several coming up, including one focusing on the implications of natural disasters, also looking at disability and trauma, and then also looking at justice-involved populations and trauma. So there's a lot coming up in the winter. Stay tuned. And thank you again, GiGi, Kelly, and Shelley. We really appreciated having you today. And thank you to all of our participants. Have a wonderful afternoon. Thank you.
Thank you.
Thank you.